Hi, you've learned a little bit about meaningful use, but let's talk about MACRA and MIPS. What's MACRA? Well, it's the Medicare Access and Chip Reauthorization Act. It was signed into law in 2015, and it created a quality payment program that repeals the sustainable growth rate formula. And this was a formula used to control costs. So that went away. It changes the way Medicare rewards clinicians for value over volume. So this is a value-based payment program instead of the number of visits a provider might do and getting paid fee for service. You now need to also prove that you're providing quality care. It streamlines multiple quality programs under the new merit-based incentive payment system, MIPS, and it gives bonus payments for participation in alternative payment models. And like many other laws, this little caveat was tucked onto it. MACRA also required CMS to remove Social Security numbers from all Medicare cards by April 2019, and prior to that, everybody was mailed a new card. So, and that was to maintain people's privacy. As some of you may know, the Social Security number was used as the Medicare number. So what is the Merit-Based Incentive Payment System, MIPS? So it combines three legacy programs, PQRS, VM, and EHR, which is the meaningful use. And the last PQRS payment ended in 2018. So since the EHR portion has been rolled into MIPS, there are a couple of exceptions. Medicare EHR incentives for hospitals will stay in effect, and Medicaid EHR incentives for professionals will remain in effect. The one area I personally, this is my opinion, feel that they could do a better job in is the fact that independent acute rehab hospitals and long-term care facilities are not required to do anything with meaningful use, and they were not included in any of the incentives. So therefore, some of their systems are very antiquated and they're not very interoperable. So it makes it really difficult when you're looking at transition of care between hospitals, long-term care, acute rehabs, and back to the hospital. It makes that documentation kind of a challenge. So the old system had the PQRS. To replace that, we have the quality pillar. So quality is still there, quality-based payments. Cost is there for performance category. There's a new clinical improvement. So if you're making improvement and you can demonstrate it, then that is helpful for your performance category. And then advancing care information, meaningful use, that's the replacement for meaningful use. This moves Medicare Part B clinicians to a performance-based payment system. But it does provide clinicians with flexibility to choose the activities and measures that are most meaningful to their practice. So it used to be meaningful use was, all or none. You had to follow those things, and this makes it a little more flexible because there are, different, for instance, providers that have different specialties. Pediatricians often complain because these were really meant for adults. So I think that's better. And then the reporting standards align with the advanced APM. So we're getting a little more consistency and some flexibility. So when did this all start? It started January 2017. Clinicians can participate at any level. The previous meaningful use was all or nothing. You had to provide data by March 31st, 2018 to earn the January 2019 payment. So it does take a while for them to pay, and payments will be adjusted on a claim by claim basis. I have not spoken to any providers about how they feel about this or any other quality people. What about commercial insurance? Well, Um, Commercial insurance probably has had more a longer time with value-based payments. So, for example, if you're in a clinic system with providers, NPs, PAs, and physicians, typically, and I had one of these positions once for a 9 clinic organization, and we would sit down with all the insurance companies, Aetna, Cigna, Harvard Pilgrim, Anthem, and we would negotiate a base payment. So that would be a base payment based on how, seeing their members in our offices. But then we would negotiate quality targets, whether they were mammograms, eye exams for diabetics, hemoglobin A1Cs. Most of this data was quality, known quality data, and hopefully our EHR was collecting it all, and that's how they typically would find, you know, whether or not we met those targets using EHR data. Now, there are other companies, health insurance companies, that requested providers to enter into some software whether or not they, the evidence for whether or not they met the quality targets. And then if you got your targets achieved, you got additional payment per member or per patient, and these could be pretty lucrative. So it was weighty enough so that perhaps you would pay attention to making sure you encouraged your patients to go get eye exams, and that you would actually order them, for instance. Now, it's been intended by most of the private or commercial insurance agents, companies, that the incentive payments are based on a per provider basis, and that the provider would get the incentive eventually. I did not find that true in my experience with the clinic system that I worked for. Most of that money went to pay for the quality people so that they could submit all this data for them. So it's kind of hard, because it's meant to reward the providers for good quality care, and it doesn't always do so. So sometimes it's up to the organization to help their providers see where they need to improve. All right, well, thank you very much. I hope that gives you just a quick overview of MACRA and MIPS. Thank you.